Welcome to the Deep Dive. Today we're tackling something pretty fundamental, maybe something you haven't thought much about. We tend to think health, illness, it's all biological.
Sure.
Or maybe about the choices we make. But what if feeling well, or even getting sick, is actually tied up deeply with society itself?
It's a really big question, isn't it? And that's our mission for this deep dive, to explore medical sociology. We want to go beyond just genes or what you eat. We're looking at how sociologists see health through social systems, through inequality, and even culture, how that shapes our understanding of being well.
Okay, let's get into that. So a core idea here, and it is kind of mind-bending, is the social construction of health. It makes you ask, well, what is a disease? What counts as illness? And how has that changed?
Oh, dramatically. Across time and different cultures. Think way back in Western history, for instance. You had humoral medicine, got a fever.
Yeah.
Maybe you need leeches, seriously. The idea was you had too much blood.
Leeches. Wow.
Yeah. And it wasn't just, primitive medicine. It was tied up with religion. Illness could be seen as God being displeased, messing with the body. That was like questioning God's plan.
So healing was almost a religious act, not just medical.
In a way, yes. Then came this huge shift with the scientific model. René Descartes, the philosopher, his idea of mind-body dualism was key.
Right, separating the mind or soul from the physical body.
Exactly. And suddenly, the body becomes more like a machine, something you can study, tinker with, fix. No divine interference needed, supposedly. It obviously revolutionized medicine. But maybe it also narrowed our focus just to the physical nuts and bolts.
And this social construction isn't just ancient history, right? It's still happening.
Absolutely. It keeps evolving. Look at the ICD, the International Classification of Diseases. It's this global standard, started way back in 1900. But it gets revised, every 10, 20 years. And not just because of new science. Big changes happen because society's views change.
Like what? Any major examples?
The clearest one is probably homosexuality. It used to be listed as a mental health disorder in the ICD, but in 1992 it was removed. That wasn't just shuffling papers. It showed a massive societal shift away from pathologizing it, from sickness to, just part of human diversity.
That's huge. It changes everything for people affected.
It really does. And on the flip side, sometimes definitions expand. Like the criteria for autism spectrum disorder have broadened over time, bringing more variations in behavior under that one diagnostic label.
Okay, so society shapes the definition of illness. But what about the experience of being sick? How does sociology look at that? What happens to you as a person when you get ill?
Right. That leads us to some key theories. One is the functionalist perspective, and specifically Talcott Parsons' idea of the sick role.
The sick role sounds like a part you play.
Kind of. It's like a temporary, socially acceptable space you occupy when you're sick. It lets you deviate from your normal behavior.
Oh, okay. So you get certain rights. Like
Yeah.
people don't blame you for being sick and you get to skip work or school.
That's the idea. Those are the rights. But, and this is important, it also comes with obligations.
Obligations when you're sick.
Yeah. Society expects you to want to get better. And you're supposed to seek help, from doctors or other professionals. Think about the classic image. Staying in bed, maybe some chicken soup, looking generally unwell, that's performing the sick role.
But what about illnesses you can't really see?
Exactly. That's a major critique. This model doesn't work so well for invisible illnesses, chronic pain, fatigue, some mental health conditions. If you don't look sick in the expected way, you might not get that social permission. People might think you're faking it or just lazy.
Yeah, that can be incredibly damaging. So how does the symbolic interactionist perspective look at this? Does it focus more on that lived experience?
It does. It shifts the focus right onto the individual's experience and the meanings they and others attach to illness. A really key concept here is stigma.
Stigma. Like we talked about the homosexuality earlier, but maybe physical too.
Yes, any characteristic, physical or social, that society labels as undesirable. It could be a visible scar or a diagnosis like HIV or even a mental health condition. That label, that stigma, profoundly shapes how you experience the illness, how you see yourself, and how others treat you.
Okay. And then there's the conflict perspective, which sounds like it focuses more on inequality.
Precisely. The conflict perspective zooms out to look at power imbalances and health disparities. These are the significant, often unjust differences in health, healthcare, and even health behaviors we see across different groups. Think race, ethnicity, socioeconomic status.
These aren't just random variations.
Definitely not. They're often rooted in social structures. For example, people with Ashkenazi Jewish ancestry have a higher genetic predisposition for BRCA1 mutations, increasing breast cancer risk. That's biological, but linked to a specific social group. Or look at asthma rates. Black children in the U.S. have much higher rates than white children. Why? Often it's linked to environmental factors, pollution, housing quality in the neighborhoods where they live due to historic segregation, and economic inequality. That's a social determinant.
That really drives home how social factors impact biology. And this connects to the idea of upstream versus downstream factors, right?
Exactly. Downstream is the stuff right in front of us, individual choices, seeing a doctor, like treating that child's asthma attack. But upstream factors are the bigger societal issues: poverty, pollution, access to good food, education, sanitation, like addressing the air quality in that child's neighborhood.
And historically, those upstream factors made a massive difference.
Huge. It's fascinating. Major drops in death rates happened before a lot of modern medicine really took off in the 20th century. Why? Better sanitation, cleaner water, pasteurized milk, improved hygiene, better nutrition, public health measures. Upstream changes saved countless lives, maybe more than individual cures at the time.
Wow. Okay, so social conditions are vital. How do different societies actually set up their healthcare systems then? How do sociologists compare them?
Well, there are different models. Take Canada, they have a socialized or single-payer system. Basically, the government funds healthcare for everyone through taxes. Doctors might have private practices, but the government pays them. Hospitals are generally public. The goal is universal access.
And the U.S. is quite different.
Very different. Mostly a capitalist private system. It's fee-for-service. You pay for what you get, usually through private insurance, often tied to your job. We have Medicare for seniors and Medicaid for low-income folks, but yeah, it's complex. And even with those, back in 2014, over 10% of Americans had no insurance at all. That number dropped a bit, but still millions.
So how do we evaluate these systems sociologically? What are the key criteria?
Usually we look at three things: access, cost, and quality. The U.S., for example, spends way more per person on healthcare than other wealthy nations. Way more. Like over $8,700 per person back in 2012, when others were maybe half that.
And do we get better results for all that money?
That's the thing. It's mixed. We actually have higher rates of hospital admissions for things that could have been prevented with better primary care. More medical errors, too. Now, the U.S. is good at treating some really complex diseases, like certain heart conditions, but overall quality for the cost. And access, it's a big debate. And that fee-for-service model can really worsen disparities. If you can't afford the fees or insurance, you might get left out or face huge debt. It reflects that structural inequality.
Trying to change these massive systems must be incredibly hard. What makes reform so difficult?
Sociologists sometimes talk about the iron triangle. It's this sort of cozy relationship between Congress, government agencies running the programs, and industry lobbyists. Think about trying to control drug prices. Lobbyists push back hard to protect profits. Congress members might get donations. The agencies have their established ways. It creates this powerful inertia against major change, often favoring the established players over, say, the average patient.
It shows how stuck systems can get.
Yeah.
Okay, beyond the big system structures, what about the medical profession itself? How does it define what counts as a medical issue? You mentioned medicalization earlier.
Right. Medicalization. It's the process where human conditions or problems start to be defined and treated as medical issues. Think about things like childbirth or aging or even sadness. Over time, medicine has increasingly claimed authority over these areas. And like we said with ICD, what's in or out of the medical domain can shift.
And tied into dealing with the medical system is health literacy, right?
Yeah.
To being able to understand basic health info.
Yeah, it's your ability to find, process, and understand the health information you need to make good decisions. And it sounds simple, but it's not. I mean, have you ever tried to read the nights after a doctor's visit? Sometimes it feels like a different language.
Totally. It makes you realize how much jargon there is.
And this is where inequality hits hard again. Think about, say, Hmong refugees who came to the U.S. Their language didn't even have a written form until the 1960s. Imagine the barriers. Trying to get health information, finding translators who understand nuance, filling out forms. It's a massive challenge and directly impacts health outcomes, sadly leading to worse outcomes sometimes compared to native-born Americans. It shows how deep structural inequality goes, right down to basic understanding.
It really does. Socioeconomic status, race, language barriers. They all impact access, understanding, and ultimately health.
And speaking of race, consent, and how the system can fail people, we really have to mention Henrietta Lacks. Her story is incredibly important here. Her cells, HeLa cells, they're basically immortal and have been absolutely fundamental for medical research.
But the story behind them is deeply troubling, especially regarding consent and race.
Deeply. Henrietta was a Black woman. In 1951, doctors at Johns Hopkins took cells from her cancerous tumor without her knowledge, without her consent. Her family didn't find out for more than 20 years. This was during segregation, a time of huge medical disparities and exploitation of Black patients.
And this wasn't happening in a vacuum, right? There was already distrust.
Exactly. You had the legacy of things like the horrifying Tuskegee syphilis study and fears of night doctors experimenting on Black people. So, taking Henrietta's cells without consent fed into that deep, justified distrust. And the cruel irony is that while her cells generated fortunes and Nobel Prizes, leading to vaccines like polio, advances in cancer research, gene mapping, her own family often couldn't afford basic health care. It just perfectly captures that structural inequality.
It wasn't just about her either. Others were affected by research practices then.
No, sadly. There were cases like researchers injecting HeLa cells into unknowing cancer patients, even prisoners, to see what would happen, again, without proper informed consent. It highlights historical ethical failures, especially towards vulnerable groups.
So wrapping this all up,
Yeah.
It seems the big takeaway from our deep dive is pretty clear. Health is just. It's not just biology. It's not just your personal habits.
Not at all. It's woven into these complex social systems, into power dynamics, into history, into inequality.
It really challenges us to look past the symptoms, doesn't it? To see the bigger picture, the societal forces shaping who gets sick and who stays well.
It really does.
So maybe something for you, the listener, to think about. Reflect on your own health experiences, or maybe people you know. How might social factors where you grew up, your family's income, the information you had access to, maybe even discrimination you faced, how might those things have shaped your health journey? And what does understanding all this mean for how we should approach health, not just for ourselves, but as a whole society moving forward?